Good evening, dear doctors. I'm Dr. Harshvi Singh Mali. I'm the head of medical affairs for Merck Oncology. And on behalf of Merck, I welcome you all for today's virtual symposium focusing on the real world evidences in bladder cancer. For today's discussion, we have national important oncologists joining us from different parts of the country, highlighting the importance of real world evidences, looking at global data, Indian data, certain case presentations, and we will also have an insightful moderation session which will be led by Dr. Vineet Talwar, sir. It's my pleasure and honor to also invite our chairperson, Dr. Dattatreya, sir. Khushi, if you can showcase to the slide, please.
Thank you.
Dr. Dattatreya, sir, of course, needs no introduction, but Dr. Dattatreya, sir, is the Director and Chief of Medical Oncology from Renova Hospitals, Hyderabad. Sir brings in, of course, more than 2 decades of clinical experience in medical oncology, and he is also a prolific speaker and a researcher. A true gamut for carrying real-world evidences, the flagship. Sir, it's our pleasure to have you for today's symposium. And may I please request you to take the proceedings ahead?
Thank you. Thank you so much, dear. And welcome one and all, and especially all my colleagues and faculty members for today's evening discussion on locally advanced and metastatic bladder cancer. If I could have the first slide, please. But what we do know is that stage 4 bladder cancer, the 5-year survival rate is around 8% or 10%. So once a patient of CA bladder has a distant metastasis, the 5-year OS drops down to less than 10%. At diagnosis, approximately 5% of patients have metastatic disease. But unfortunately, after cystectomy also, metastatic relapse is significantly common, so much so that 50% of patients relapse after cystectomy. And almost 70% of these patients who relapse after cystectomy would be having distant metastasis. The bottom line, therefore, becomes that patients with locally advanced or metastatic bladder cancer have very poor outcomes. So this is what I was talking about the 5-year OS for stage 4 bladder cancer being only 8%. And despite a radical or a partial cystectomy curative intent, the disease can come back with metastasis in almost 50% of patients. And once it relapses, a significant proportion of these relapses are in the form of distant metastasis. We'll just try to look at some Indian data. Next slide. In India, we rank 7th in the high with regard to the incidence of bladder cancer across the world. But in mortality, we rank 3rd. We rank 3rd, which means that with regard to the treatment outcomes, probably further improvements have to happen so that the gap between the incidence and the mortality can be reduced. And so in the last decade, next slide, especially from 2014 onwards, we have seen a flurry of activity with regard to treatment landscape, and that's evolved rapidly with the incorporation of immuno-oncology molecules, antibody drug conjugates, and various combos like ADC plus IO or chemotherapy plus immunotherapy, or including the usage of maintenance immuno-oncology molecules. So this landscape in the treatment for locally advanced or MUC has evolved rapidly, especially in the last decade. Next slide. Our meeting objectives today are to know and understand the strategies for early and locally advanced metastatic urothelial carcinoma. Number 2, to discuss real-world evidences and clinical case studies, and then to apply these evidence in clinical practice, finally ending up with optimizing the treatment sequence to maximize patient survival. And so we have real world evidences in advanced bladder cancer, global data, Indian data, some interesting case presentations, and followed by a panel discussion moderated by Dr. Vineet Talwar and his esteemed team of panels. So, with this, I would now hand over the podium to Merck Medical so that the proceedings can start with a discussion which will be compact and concise on understanding real world evidence and clinical case studies. Thank you so much.
Thank you so much, sir. And with that, may I please invite Dr. Chandra Gaurav, sir, for his session on real-world evidences in advanced bladder cancer, looking at the global databases. Dr. Chandra Gaurav, sir, is the director in medical oncology at Max BLK Hospital in Delhi. Sir, may I please request you to take over the proceedings?
Thank you, Doctor. Thank you, Mark. So you already shared the slides. Okay. Shall I share it?
So you can share
Yes.
it from your end also, please.
Yeah, I'm doing that.
Sure.
I hope these is I'm audible and the slides are visible, right?
Sir, very clear. Thank
Right.
you.
So this is actually a real world evidence data from the global perspective. And we have all know that the bladder cancer landscape has changed a lot from 2014 to 2020, and in the last 5 years has given us a lot of molecules. So we used to talk about platinum ineligible, cisplatin eligible or ineligible, where either the gem carbo gemcis followed by the other agents used to be there. Now, with that, the objective response rate, as Dr. Dattatreya has already pointed out, was dismal. And again, this also has been pointed out very nicely that if we start patients on treatment, so baseline is 100%, and when they reach the first line, almost 50% would have dropped, and subsequently the drop is very huge and rapid. So when they reach almost a third line, it's only 6% of the patients who are alive. So that made us to think what else we can give in the down the line. How do best sequence treatment to make eligible a lot of patients and then give a better survival. So we know that the first line treatment has been approved 3 lines. So it is a platinum gemcis or gem carbo followed by avelumab maintenance, or gemcis with nivolumab followed by nivolumab maintenance, or in a platinum ineligible is EV plus pembro, which has recently been approved. What after that is what needs to be answered. So the sequencing of that. So in these two first lines of treatment where you give avelumab maintenance, you can sequence it either EV or adafrutinib depending on the FGFR mutation. But when you talk about EV pembro, there some sort of a confusion exists where you have an option of only chemo. So in the Javelin Bladder 100 trial, the subsequent treatment where you can just see that the patients who out of 700 patients, there were the avelumab plus best supportive care, 75% received the subsequent versus the best, but almost somebody who was on best supportive care, the subsequent line of management was did not different from best supportive care, which indicates the large majority of them, 2/3 of them received a subsequent line of treatment in a Javelin 100 trial. The most common other drug received following the avelumab's first line maintenance were gemcitabine, carboplatin. That usage depends on the duration that was depicted in the paclitaxel, vinflunine, and the cisplatin. So there is a limitation of last phase 3 randomized trial, as you need to on the left hand side the randomized and on the right side you get retrospective observational data. So they were treated as per the protocol. So actual care of that patients received in the clinical practice. The patients are selected according to the inclusion and exclusion criteria and strictly abide by that. So the patients receiving contemporary sequences in trials may not reflect the real world evidence. So that needs to be seen. So what we learned from the real world data, our phase 3, the phase 3 efficacy in the toxicity data that we see in the routine practice. So this is available RWE for available maintenance across the globe. So where more than 2,500 patients with locally advanced metastatic urinary bladder cancer globally, with additional data still upcoming. So Europe, it's more than 500. And in the US, it is more than 500. Europe, it's more than 1,300. In Asia, it's more than 1,000 patients. So if you talk of the survival outcome for first-line myeloma maintenance, they are consistent with what the real-world studies. So this median PFS 5.5 across all the real-world data, and the 12-month OS rate was of 70%. The median OS also was almost similar. If you can see the 23-month, 8.8 months, and the median OS from the start of the first-line platinum-based treatment was 29.7 months. So that's what it is. So real world evidence, that is advanced study, if you just go into the detail of it. And this is a patient with previously ongoing or planned avaloma first-line maintenance treatment that did not progress in first-line platinum-based treatment. So then again, it's similar to what we have Javelin, and the primary endpoint is OS, and the secondary endpoint, various secondary endpoints. So this result, the PFS OS are not different from what we see in the Javelin. So median OS was 21.3 and PFS 5.7 months. So historically, in a real world study, 25 to 50% of the patients with locally advanced or metastatic were receiving subsequent treatment following first-line platinum-based treatment. So almost nearly half of the patients. So this percentage of patients receiving subsequent line after platinum-based treatment and avaloma first-line maintenance due to disease progression. So in Javelin, it is 75%. In the real-world data, it's almost 82%. They're correlating with the real-world data. So if we just talk about maintenance and the sequencing data from as far as the advanced data, we can see after 2 years of follow-up in all those patients, 3 in 4 patients were still either receiving the avelumab or received a second-line treatment. That indicates that a lot of patients are ongoing on this particular treatment. So even the ADC was received in 18.8%, chemotherapy in more than 2/3 of the patients. So the contemporary sequence of Javelin Bladder regimen followed by a second-line EV, which resulted in a median OS of over 40 months, which is definitely huge considering the disease status and what it used to be and what is now. So in Japanese real-world data, the complementary findings to advance ensured a median OS of 40.3 months, similar to what the real-world evidence suggests. So further Japanese real-world data showed that the 42-month median OS, 95% confidence interval, with the first-line platinum-based treatment followed by IV maintenance, including 13 patients treated with avelumab first-line maintenance followed by EV. So that's reiterating the fact. So that brings us to a point that improving outcome for patients with platinum-eligible locally advanced metastatic. The real-world evidence gives us a lot of confidence in using it and sequencing the treatment. And if you talk of EV plus pembro on other side of the game, so which this is again Unite EV sub study design, and in a first line treatment overall response was 54%, and disease control was 88. So how does this compare to the real world data? That's what I'm going to with compared to the EVP. So if we talk of outcomes with EVP in a real world study, so it is a real world study, and the ORR was 54%. However, in EV 1033 for hot AK and then the E03302, so that's where the randomized trial, where that was 67%. The 12-month PFS was almost 15 in the randomized trial versus 30%. So 12-month OS was 78.2% versus 67%. So ORR and 12 months PFS and OS were comparatively low in the real world data compared to the randomized data. That may be due to various reasons where per protocol follow as well as the strict stringent dose regimen and the inclusion criteria. So that does matter. So effectiveness of first-line EV plus in real-world population. So this is again a data reiterating the fact that this highlight the reduced effectiveness of EVP in those with certain So certain urothelial cancer subtypes, so the variant histologies, distant or a bone metastasis, or those failing to achieve early ctDNA clearance. So these are all the retrospective data failing that the histology also plays a role, as well as the metastasis and the ctDNA. So what are the considerations for subsequent EV plus Pembro? So you have a EV Pembro for the first line, then the second line, and if they are eligible for the platinum, then we just give a platinum combo. And the beyond second line, then you have, depending on the NGS data, to erdafitinib or sacituzumab obiticin or a clinical trial. So when you need to consider this, how to manage the cumulative toxicities that is neuropathy due to EV. So definitely, a lot of us definitely reduce the dose and as well as the number of cycles. And what are the best second line options? Then what proportion of these patients would end up receiving the chemotherapy? Can available maintenance can be considered in the second line? That's a big question, as patients would have received already pembro in the front line. So this is EV302, a subsequent line of treatment. You can see first subsequent systemic treatment was received in only 1/3 of the patient, 28% of the patients, compared to the CTR, which was 2/3. So the platinum-based treatment was in 1/3, and the subsequent immunotherapy was single-digit number compared to chemo, where 60% of them have received it. To conclude, as per the locally advanced metastatic urothelial treatment landscapes evolves, it becomes increasingly important to understand how therapies are being used in practice and their impact on the real world. So worldwide real world data substantiates the benefit that was seen by Javelin 100 in terms of a PFS, in terms of a median OS survival, and the overall survival starting with the first line platinum-based treatment. So they are matching with what Javelin 100 says. So if you sequence it properly, there's a 40.8-month median overall survival. So it is crucial to consider effects of sequencing to improve the outcomes of patients, including managing toxicities and determining optimal treatment and duration. Thank you very much.
So thank you so much for that insightful lecture. Of course, you also looked at the recent most data points coming in from ASCO 2025, sorry. So we will also have some question and answers and more discussions during the panel discussion. And that also brings me to inviting the next speaker. Our next speaker is Dr. Vivek Agarwala, sir. I'll just share my screen for a bit. Dr. Vivek Agarwala is the director at the Department of Medical and Hemato-Oncology at Narayana Super Speciality Hospital in Kolkata. Sir, we welcome you for the meeting, and may I please request you to take over the proceedings for your session. Vivek, sir, will you want someone to showcase the slides, or will you be doing it at your end?
Slides. And yeah, and congratulations to Mark for organizing this meeting. I think it is a very apt meeting to look at, because they are only concentrating on real world data and real world evidence. And we all understand that in today's era, the patient that comes to our clinic has multiple issues, because of which they may not be the correct candidates, and whether they would have actually being eligible for the original clinical trial or not, it's sometimes a doubt. And hence the real world data and experience sharing does help us in understanding how the molecules do in actual practice in real world, where the setting, the patients may be different as compared to the clinical trials, where they are strictly monitored, and the outcomes may be different. Yeah, can I have my slides? So the slides have been given to me by the Merck, and today I'm talking about the real world outcome for maintenance avelumab treatment in Indian patients with locally advanced metastatic urothelial cancer. Next slide. So basically, this is an Indian data, a multi-center data that has come from principally from 4 different institutes, that is Rajiv Gandhi Cancer Institute and Research Center, Delhi, from Elite Himat Oncocare Center, Surat, from BLK Max Hospital, Delhi, and Shayadri Hospital, Pune, as well as the TMH Varanasi. So this was the poster that was presented at ISMPOCon 2024 by Dr. Vineet Talwar, Dr. Kaushal Patel, Dr. Chandragowda D, Dr. Tushar Patil, and Dr. Akhil Kapoor on the real-world outcomes for maintenance avelumab treatment in Indian patients with locally advanced or metastatic urothelial cancer. Next slide. So the background is avelumab maintenance after first chemotherapy, locally advanced or metastatic urothelial cancer, has shown overall as well as progression-free survival benefit in the Javelin Bladder 100 study. From patient receiving avelumab maintenance, something that is the need of the hour. Next slide. So this was a multi-center, non-interventional, retrospective patient cohort, patient records review, which was carried out for patients who are treated with avelumab maintenance. The survival outcomes were established using the Kaplan-Meier method. The key outcomes that were measured is the objective response rate, progression-free survival, and overall survival. The data, the quantitative variables were summarized as either mean or median, while qualitative variables were presented in the form of frequency or percentage. The survival outcomes, including PFS and OS, were analyzed using the Kaplan-Meier survival curves. Next slide. So these are the baseline demographic characteristics. So in the total of 42 patients who were included, they had a median age of 64 years and 81% of them were male. The primary tumor, the upper tract tumors were lesser, 16%, while the lower tract were 57%, and 26% the data was missing. And after first line chemotherapy regimen, this is what something we have to note is that most of the patients received gemcitabine carboplatin, 52% of them. So this is something very different from the clinical trial setting where most of the patients received gemcitabine cisplatin. But in real world setting in India, what we see is majority of patients were receiving gem carboplatin as their first line chemotherapy. So after the first line platinum based chemotherapy, there were 11% patients, 11 to 12% patients, 5 patients out of the 42 who achieved complete response, whereas majority of the patients, 60% almost, had partial response. 11 patients, that is 26%, had stable disease, while in one patient, the data was missing. So if you see, this is something I would say that there is one of the criticisms of this data, that there is hardly any progressive disease in the first line chemotherapy. And even in real world, we see around 10-15% patients who are going to progress initially only on the first line treatment. But out of all the 42 patients, progressive disease is not documented, which is, I think, one of the, I would say that one of the criticisms of this data. If you look at the treatment-free interval, so in the original Javelin 100 study, 10 weeks interval was allowed between the chemotherapy and starting of avelumab. And here, most of the avelumab was started within 10 weeks only. So within 4 weeks itself in 26% patients, 4 to 6 weeks in 54% patients, and 6 to 8 weeks in 14% patients, while this data was missing in around 5% patients. Next slide. So I think they included only patients who had progressed on first line treatment, and that is the reason why the PD data is not there, and all the responding and non-progressive patients were taken. So I think that is the reason why we don't get a PD patient, because this is only respected to the avelumab data. Yes. So these are the results of the PFS, and the median duration of avelumab maintenance was 6 months with an overall response rate of 16.7%, and 4 patients had a complete response while 3 had partial response, and the median progression-free survival was 5 months. And this is the curve that you can see. And patients who received avelumab for more than 6 months, in that category of patients who were more responding, the median PFS was 11 months. So in all the patients, 5 months, and in the patients who were responding and who did well and were able to receive avelumab for more than 6 months, the median PFS was 11 months. Next slide. I think there was a OS data slide also. Yeah. So the median OS was definitely not reached because it was a short follow-up. But at 12 months, the OS rate was 82%. And the PFS as well as the OS data, what we see here is actually in line with the principal Javelin 100 study. Yes. Next slide. So the conclusion was that this multi-center Indian real-world data confirms that avelumab maintenance treatment's efficacy is consistent with the previously reported clinical studies. Next slide. So if you take my opinion on this data as well as my experience, I think the experience is not very large. And few of the patients we have used lower dose of avelumab also because of the financial restrictions. But what we have seen is that patients where partial response to baseline chemotherapy, the initial chemotherapy is there. These patients and patients especially who have a low volume disease and patient who do not have visceral disease. So these are those patients who seemingly they do better on avelumab maintenance, and these are those patients who are expected to do better. So with this, I thank you all for patient listening, and over to Merck for carrying forward the further proceedings. Thank you.
Thank you so much, Dr. Vivek sir, for sharing the Indian real-world evidences and your clinical experience also. With that, we will be moving into the case presentations. Our first case presentation is by Dr. Abhishek Kumar Singh. Dr. Abhishek Kumar Singh is the Director in Medical Oncology at Medanta Hospital in Lucknow. Dr. Abhishek sir, may I please request you to take over?
Yeah, good evening, everyone. Wonderful discussion already has been made by Dr. Chandragowda and Dr. Vivek Boss. And they have already made things very clear. What is the standard recommendation and what is the real world data from our Indian setting as well. So just I'll go ahead with the case presentation. Though this case is a old case, I'll just quickly go through the slides. And so this patient is 77-year-old male. He was diagnosed a case of metastatic carcinoma urinary bladder, and he had bone mets at presentation. The onset was March 2021. He had comorbidities, diabetes, and hypertension, and biopsy was done, which I'll be telling in the next slides, and that it was a high-grade invasive urothelial carcinoma, and PET scan was suggestive of a tumor originating from the base of urinary bladder from the left posterolateral wall. Next slide, please. So this is the CT finding, and it was suggestive of mass which was originating from the left posterolateral wall. And biopsy was done, which was suggestive of high-grade invasive urothelial carcinoma. Next, please. This was the baseline PET CT scan, which is showing that there was a mass in the bladder, and also there was some FDG-avid lesion in the bone. And we can see in the slide provided that there were some lytic lesions in the vertebra, and that's why the disease was metastatic upfront. CA urinary bladder along with the bone metastasis. Next, please. So, as per the standard guideline, this patient was given chemotherapy, gemcitabine and carboplatin based, and he had comorbidities and baseline creatinine was also not, it was slightly higher side. So cisplatin was not used, and patient was given gemcitabine and carboplatin along with the GCSF support. He received standard day 1 day 8 schedule. 3 cycles he was given, and after 3 cycles, patient was explained already that his disease is stage 4 and it is not curable. We have to give a treatment which can give us a good control, and then there will be a plan to give a treatment which can give us a, prolonged PFS benefit. And that's how 3 cycle was given, and patient completed cycle 3 day 8 in May 2021. Next please. After this third cycle, the PET scan was done, and it has shown that the baseline PET scan was compared with this new PET scan, and it has shown that there was reduction in the primary side, and also there was resolution of the skeletal lesions, and there were no new lesions, and patient was further 3 cycle more of same schedule chemotherapy, gemcitabine, cisplatin, carboplatin was given, and it was completed till July 2021. Next, please. And this after 6 cycle of PET-CT scan, this is the scan which was again compared, and though there were reduction in the primary and the bony mets already had disappeared, there were new active FDG-avid lesions in the both the lung fields, and which they were the new findings. And then it was the time when the data in favor of avelumab was there, and patient was planned to give injection avelumab 600 milligram every 2 weekly. Initially, it was planned to give 6 cycles, and it was planned that patient would be given 6 cycle and followed by PET scan to see the response assessment. Patient completed 6 cycles till August 2021. It was started from August 2021 and completed in November 2021. Next, please. And this was the PET scan after this November 21 last cycle of 6 cycle of avelumab, and it is showing that the patient was responding, and the lung lesions also had disappeared, and they were responded well, which we can see in this PET-CT scan film, and it was compared with the previous PET. Almost all the lung lesions, they have disappeared, and there were no new lesion, any FDG lesions has appeared. Next, please. So this is what I have just mentioned, that patient had very good response to avelumab, and then it was planned that patient will be given as avelumab maintenance further, and patient continued taking this maintenance therapy. Next, please. And almost this is the time frame when patient has received, and regularly patient has received immunotherapy with the almost no side effects, and patient tolerated the regimen very well, and he could complete. Next, please. He could complete the and this is the PET scan after 13 cycle, and we can see there was no lesions in the anywhere in the body, and patient was tolerating it well. There was no side effect which of any concern, and same thing was continued, and patient continued taking avelumab maintenance, and I think almost 22 cycles he has received. Go to the next slide, please. You can skip this one. Next, please. So he received almost 22. I mean, this is the 14th cycle which he has received on March 2022, and there was no toxicity. Patient tolerated well. Almost 22 cycles he has received. Next, please. With almost 11 months of PFS, and after this 22 cycles, there was some progression. So this is the story that definitely the standard regimen is cisplatin based chemotherapy. Patient once they respond well, we can give them avelumab maintenance in the first line. if there is progression also in the second line, there is data which is in favor of avelumab maintenance, which can be given. Tolerance, there is no concern. I mean, I have been using it, and everybody who is in oncology practice, they are using it for quite long now. And concern, there is no such toxicity concern, especially the immune-related toxicities. I don't have any experience of immune-related toxicity with this drug. So I think well tolerable regimen and preferred regimen for in this scenario. I think this was the last slide. Go to the next, please. Yeah, thank you so much. Over to the organizers. I mean,
Thank you so much, Dr. Abhishek sir, for sharing your case experience. That has been quite insightful, coming to know what is happening in the real life clinical scenarios. Thank you for sharing. May I please invite Dr. Saurabh Kumar Mishra sir. Dr. Saurabh Kumar is, of course, the Associate Professor at AIMS Bhubaneswar. Sir, it is our privilege to have you for today's case presentation. May I please request you to take over?
Harshdeep, can I share my slides? That would
So
be
you
okay.
can definitely do that, sir.
Thank you. So is this visible, my slides?
So we can see them. Yes, sir, we can see it in full screen mode now. Thank you so much.
So good evening, everyone. Thank you, Mark, for this opportunity. So I would be highlighting a case or a patient where sequencing in metastatic urothelial carcinoma would be my preferred option. So what I'm going to highlight is first line avelumab after maintenance after chemotherapy, and then subsequently enfortumab vedotin. So this was a patient who was initially diagnosed actually in 2021. So he was diagnosed in the Department of Urology when he presented with hematuria and low in pain. And initially he underwent a surgery which was incomplete, and subsequently this patient underwent a completion surgery that was in 16th of November 2021. That was a laparoscopic radical cystoprostatectomy, total urethrectomy, ileal conduit, and pelvic lymph node dissection. So final histopathology, they reported as two malignancies. One was the PT2B-N0 MIBC high-grade urothelial carcinoma, that was the bladder, and also a high-grade urothelial carcinoma of the urethra. Subsequently, he underwent a ileal conduit repair and bilateral PCN on the 1st of December 2021. This patient should ideally have got some form of adjuvant therapy. That point of time did not get. So after a duration of around 1.4 years, that is the disease-free survival, a disease-free interval of around 1.4 years, this patient presented to us in April 2023. At that point of time, he had multiple liver metastasis, a poor prognostic subset, and extensive bony lytic lesions. He was, however, absolutely fit patient. And therefore, based on his cisplatin eligibility, no exposure to prior chemotherapy, we went ahead with the dose-dense MVAC regimen. At the same time, we also started on denosumab. The next generation sequencing was sent, which showed pathogenic mutations in the TP53 and the androgen receptor. PDL1 was negative. This patient received 6 cycles of dose-dense MVAC till 24th of May 2023 with the best response. He had a favorable partial response, clinically significant improvement, very limited amount of toxicity. At that point of time, this patient was started on avelumab maintenance based on the Javelin trial. So he started on avelumab 800 milligram 2 weekly from 7th of July 2023. And there were no overlapping toxicities with chemotherapy and avelumab. It was started almost around after 6 weeks of completion of chemotherapy. So with avelumab, there was an incremental response. So whatever was the response after chemotherapy, there were certain additional responses also. So after a duration of around 4 months of avelumab, that is started in July 2023, the patient actually progressed on the 24th of November 2023. So on avelumab 4 months and then chemotherapy around 4 months. So first line PFS progression-free survival was somewhere around 8 months. Although the patient had responded to avelumab, it was short-lived. However, at that point of time, since there was no mutation, enfortumab vedotin was not available in India, it had to be imported. So therefore, during the interim, because the patient was getting clinical benefit, there was no symptoms to the patient, this was a radiological progression, we continued on avelumab till 23 of January 2024. By the time enfortumab vedotin landed in India, and the bilirubin had shot up to 2, around 2, which is around 1.5 times the upper limit of the lab normal. So at that point of time, this patient was started on enfortumab vedotin at a full dose. That was the day 1, 815 every 28 days. And with the initial dosing of enfortumab vedotin, the bilirubin actually shot up to 7.11 on the 13th of February. However, subsequently on follow-up, the bilirubin started dropping and the patient was re-challenged with enfortumab initially at a low dose, and subsequently we were able to give enfortumab vedotin at a full dose. So from 10th of February till 2024 till 23/11/2024, so in the second line, this patient received enfortumab vedotin. This was the chart of the bilirubin. You can see initially at the baseline it was around 2. That was the full dose was given, immediately shot up to 7. At that point of time, there was some delay, but gradually we started coming down. And when the bilirubin was around 4, we gave the second dose at a reduced dose. And gradually the bilirubin, as the disease started to respond, by the second cycle within a span of around 2 months, the bilirubin had totally normalized, coinciding with the responses with enfortumab vedotin. If you see the dosing of enfortumab vedotin in the liver impairment, so with mild impairment, that is up to 1.5 times upper limit of normal, there is no dose adjustment. However, it is not recommended in moderate to severe impairment. However, as we can see here, with dose limitation and decreasing the dose, and if the patient can tolerate with a very aggressive disease, we can still get responses in the setting of advanced, in the setting of hyperbilirubinemia. This was the best response we got. So the almost you can see on the left hand side, so many lesions are there. And this is on the right hand side. And enfortumab an excellent response, which translated into the favorable partial response. This patient was still having an extracranial control when he had a florid progression in the brain, intracranial progression, while on enfortumab. Around 9 months of enfortumab was already given. Whole brain RT was given. Patient developed liver failure subsequently due to multiple other causes and succumbed to the disease. So by that time, patient had already received 9 cycles of enfortumab. So the second line PFS with EV was around 9 months. So overall survival from the onset of metastatic disease was 22 months. This is good considering a real world data and considering that even in the EV302 trial, when the first line EV plus Pembro in the setting of liver metastasis, the median overall survival was around 19 months, right? So enfortumab vedotin is not an easy drug. So there are toxicities, as I said. So skin toxicity is a major problem. It persists, actually keeps on happening. So you have to take multiple consultations. The neutropenia also happens. Bilirubinemia happens. Alopecia is a problem. So these are some of the toxicities. So it's not that it's an easy drug, unlike avelumab, but still the responses also are great. So what I would like to conclude here is that sequencing is an appropriate strategy to optimize the usage of the most effective drugs. Avelumab is an effective drug, and enfortumab is an effective drug. So sequencing first avelumab maintenance at progression and enfortumab seems to be reasonable options for our patients. And the patient on avelumab maintenance, there is still an incremental response. Avelumab is a well-tolerated regimen. EV in the second line still has robust responses. However, it is a difficult drug and needs to be handled appropriately. So once again, I would like to thank Mark for the opportunity and thank you.
So thank you so much for sharing this great presentation. Of course, it reiterates in clinical practice the clinical scenarios that you all decide upon for selection of drug, be it for first line and second line. Of course, with this case sharing and by the presentation by Dr. Chandrugoda earlier from the Evinan study, as you have also positioned it, avelumab first line maintenance, EV in the second line helps the patient for a long-term survival. With that, and taking the proceedings ahead, we will now have a very interactive and insightful panel discussion. led by Dr. Vineet Talwar sir. Of course, Dr. Vineet Talwar sir needs no formal introduction, but sir is the director, Department of Medical Oncology at Rajiv Gandhi Cancer Institute and Research Center in Delhi. Uh, Khushi, just give me a moment. Let me share my screen, please. Sir has been serving the Department of Medical Oncology since 2000, May 2000, and has over 140 publications to his credit in various national and international peer-reviewed journals. Sir's key area of interest, of course, includes genitourinary medical oncology, GI oncology, and it is our fortune to have him lead the moderation session today. Sir, we welcome you and are looking forward to the insightful discussion. Joining you, of course, within the panel, we have a very good panel joining you from different parts of the country. Dr. Minish Jain, sir, joining from Ruby Hall Clinic, Pune. Welcome, Dr. Jain, sir. Dr. Ravi Thippeswamy, sir, from SCG Bangalore, SCG Hospital in Bangalore. Dr. Shashankar Shekhar Das from SCG Hospital, Kolkata, and all our earlier faculty, Dr. Chandra Gowda, Dr. Vivek Agarwala, Dr. Abhishek Kumar Singh, and of course, Dr. Saurav Kumar Mishra also joining in for the panel discussion. With that, Dr. Talwar sir, may I please request you to take over the proceedings?
Thank you, Dr. Harshveer. Am I audible?
Sir, very clear, sir.
Fine. So you can have the flow of slides from your side. So
Sure, sir.
can we have the first slide, please?
Khushi, if you can please share slide, please.
So this is basically a reiteration of what has been discussed till now. That is the studies which have been there for the advanced bladder cancer, followed by the real world studies, and of course, some case studies which have been alluded to you very nicely. So next slide, please. We'll be discussing about the advanced bladder cancer and the nuances, how it has evolved, and what are the choices which we have now in the first line. So these are my esteemed panelists, Dr. Ravi, Dr. Minish, Dr. Shashank, Dr. Chandra Gowda, Dr. Abhishek, Dr. Saurav, and Dr. Vivek. Next slide, please. So as you see, as it has been discussed, initially we had only cisplatin, where you had a OS of about 12.5 months when it was used in combination rather than alone. And then after that, we had a combination of MVAC and DDP that also was used in the metastatic setting. Subsequently, after a very long hiatus, that is from 1990s to 2020, almost 30 years, you have avelumab, which has shown that there is a OS benefit when you talk of maintenance treatment. So if you have a patient who is doing very well in the metastatic setting, who has responded, who has had a very good partial response, then the next obvious question would be what to do. Earlier, we used to tell the patient, since you have had an excellent palliation, you can be put on follow-up, and we'll intervene only when the disease progresses. But now, fortunately, we had in 2020 avelumab, which not only acted as a good maintenance, switch maintenance, but along with that, it definitely prolonged the overall survival. Next slide, please. So here we have jumped from 12.5 months to almost 24 months. So it's a doubling of the survival, and that definitely became the new standard after the conventional chemotherapy. Next slide, please. So let us have a feel from all the panelists. We start from Dr. Minish. Dr. Minish, these milestones in your clinical practice, has it made any changes when the final treatment comes, when the patient is sitting in front of you?
Yes, immunotherapy has made an impact in every oncology malignancy what we are treating today. and bladder cancer is no exception. Definitely, we are using immunotherapy nowadays, and it's used either sequentially or along with the ADCs or along with chemotherapy, and it is definitely impactful. So I would say that yes, and all the subsequent drugs, even which are coming, targeted therapies, are also making a difference. So we do say that there is a small difference, but all these small differences have doubled or tripled the survival in patients.
Right, Dr. Ravi, a quick
Yes, sir. No, definitely. As sir said, immunotherapy is the way to go, and either we combine with the treatment or sequence it. But in urinary bladder, we have seen that once they achieve some response, giving available maintenance is a very good strategy for better PFS with good quality of life.
what about Dr. Shashank?
Yes, sir. Sir, as we go for, as we are, as you can see that there is a rapid evolution of treatment in urinary bladder, and currently lots of molecules have came, and now we are in the landscape is rapidly changing, and now we are in the sense we can switch over from without any chemotherapy to an ABC plus an immunotherapy. And what dilemma we face previously, that if the patient was not having a fitness for platinum based chemotherapy, what we can give, that dilemma can be is usually is currently becoming solved.
Yeah, very rightly said, Dr. Vivek. Anything you want to add on to it?
So I think same, sir, what everybody has said, that now suddenly in the last 4 years or so, we have now multiple treatment options. Whereas, as you said that, a decade ago, we just did not have any other options apart from chemotherapy. There was some, talk about gemcitabine maintenance after a gemcis. And I think there is the retrospective data from your center only, which has shown some clinical benefit, which probably a few of the centers were using before. But I think chemotherapy may improve your PFS, but it hardly improves the overall survival. And
You're right. When you
yes,
talk of a doubling of the survival,
correct.
the switch maintenance has revolved the thing upside down, totally
Yes.
360 degrees. Dr. Abhishek, your thoughts at the inception?
Sir, if the finance is not a problem, definitely first line maintenance is the uh, thing which I think everybody is practicing, and it is definitely beneficial. Um, and I think it has probably some changed the dependency on the cisplatin regimen also. Maybe the cycle also, which 6 cycle we used to give, we can reduce it to 4 cycles if the patient is responding, and we can start the maintenance early also. So I think it is way forward. I mean, we have very strong data and practical scenarios also where people are using it and results are there.
So basically, you have the doubling of the OS, you have the flexibility of switching over either at 3 or 4 or 6 cycles, and definitely you have the doubling of the overall survival. Uh, Dr. Saurav, anything you have in your mind?
Sir. So I would say, sir, with all these results, still cisplatin eligibility holds a very important part, and platinum eligibility still holds a very important part in clinical decision makings for our patients. And with these drugs, definitely we are seeing remarkable responses, even with the most difficult to treat and aggressive subset of patients.
Yeah, nicely said. So all of us, we are agreeing on the fact that there has been a quantum leap when you talk of chemotherapy only followed by chemotherapy and a switch maintenance, which does not require any biomarkers, which could be given apart from that. So next slide, please. And this is the trial where which has been discussed. I will not go into the details. Suffice to say that the primary endpoints were overall survival, And this was in all randomized patients, and also the PD-L1 population was checked. Next slide, please. And as you can see that long-term outcomes are there, and you have median overall survival of 29.7 months, and this is having a very good hazard ratio also of 0.77. Next slide, please. And there was a talk of whether you can give it after 3 cycles or 4 cycles or 6 cycles, or whether it is cisplatin or carboplatin, or the duration, whether you have to give immediately on completion of treatment. You can stretch it for about a couple of months. And of course, irrespective of the response, whether it is a complete, partial, or a stable disease, you can always use this drug, and you have the responses in all the 3 categories. Next slide, please. So I'll put this to Dr. Ravi. When do you initiate avelumab after the first-line chemotherapy?
Generally, in our practice, we call the patient after 3 to 4 weeks after completion of last cycle of chemotherapy with the assessment scan. And majority we will start at that point, sir.
Yeah, so that is the general idea. Dr. Minish, are there any differences amongst cisplatin or carboplatin-based chemotherapy for the initiation of avelumab maintenance?
No, there is no difference. You can give avelumab to anybody, but definitely I feel that patients who are eligible for cisplatin are more fit patients. They are anyway going to take a better drug compared to carboplatin. So their outcomes are anyway selected to be better. So if somebody is fit for cisplatin, is more fit, and cisplatin is better response than carboplatin. So these patients I prefer, and avelumab is given to everybody, and avelumab in fact becomes more important to patients who are receiving carboplatin, because you have used chemotherapy which is the lesser effective dose, I would say, compared to Gemcis. So
Yeah,
I would
you're
use
right.
avelumab in every patient who is affording post treatment.
Paradoxically, it was seen that patients who were given carboplatin instead of cisplatin, they were doing a shade better in the trial. But I think in the real life setting, cisplatin is any day preferred if the patient is cis eligible.
No, that's what I'm saying, that you know you are
Yeah.
giving to patients who are anyway poor with chemotherapy. So avelumab adds better benefit to patients with carboplatin compared to cisplatin. That is what I was trying to highlight.
And how long would you continue this maintenance? That question.
As long as the patient's financial conditions permit.
Sir, can I ask a question, Vinit,
Yeah,
sir?
sir, please.
So, sir, I would just like to ask you, what about you have a recently you had data from your center on dose dense MVAC. So, how do you feel this regimen, if avelumab maintenance, if at all you are planning? And second thing is, if at all GemCis you are using, is it the day 1815 or the day 18 only? That's what you are using.
You use gem alone, then it is 1815 Q4 weeks. If you use it in combination, that is Q3 weekly, day 18. And what was the earlier DDMVAC?
MVAC, yeah.
MVAC or DDMVAC? Well, that is always a point of contention when we talk of maintenance. And as Abhishek had nicely mentioned that India is a price sensitive market. So wherever those patients who can't afford this, that is another choice which can be given to these patients. Definitely, yes. So next slide, please. So this is the median progression-free survival on these. So the question was how long to continue. So you find that in the study, most of these patients had been exposed, almost half they were exposed to about 6 months. And as you go up the ladder, it's about 30% for 1 year and about 20% for 2 years. So generally, most of the patients, or rather half of the patients, could take the drug for 6 months at least. Next slide, please. So now, as I said, there was a quantum leap from 1980s to 2020. After that, two more new trials came. One is the Checkmate 901, in which Gem, Cis, and Neo was pitted against Gem, Cis. Next slide, please. So this was the schema. This is Gem, Cis, Neo versus Gem, Cis, 1:1 randomization, and treatment till unacceptable toxicity or progression of disease. But mind you, this was a sub-study. This was not the main study. And the main study was a negative trial, and only this sub-study was a positive trial. And it had its own primary endpoints, that is OS, PFS, and key secondary endpoints, which were quality of life indices and toxicity profile. Next slide, please. So you find that there is a benefit of about 3 months as far as the overall survival is concerned, but unfortunately, there's hardly any difference in PFS, which seems very surprising. And also this benefit is seen after 6 months. So a quantum benefit of about 2.8 months against what was almost a doubling when you saw switch, and the PFS was hardly any, 0.3 months. And here, if I may were to add, the maximum benefit was in those patients who are lymph node only positive patients, which probably constitute about 10 to 15% of the overall metastatic population. Next slide, please. And of course, these subsequent therapies, only a limited number of patients were on maintenance avelumab. A higher percentage would have been able to give us better results and a comparison and reduce the bias further. Next slide, please. So the obvious question is that there were 3 trials prior to this in which they had a combination of chemotherapy plus immunotherapy, in which you had atezo and pembro, and they were negative trials. How come this sub-study was a positive trial, despite the fact that the OS was only 3 months more? Any thoughts, Saurabh? Why the previous trials failed and how come this became positive?
So one thing could be that probably this strategy, which is on concurrent immunotherapy along with chemotherapy, may not be the right strategy, at least in bladder cancer. So probably maintenance strategy after there has been a reasonable response with chemotherapy is probably the optimal approach in bladder cancer. And therefore, I believe that probably this study, the previous studies with immunotherapy were negative. And as you said, in the Checkmate study, there were benefit was mainly in the limited burden disease, that is lymph node metastasis, and where patients did not receive the standard of care avelumab in the comparator arm. So these are some of the points I would feel.
Yeah, you're right. Next slide, please. So the other thing was there was a reanalysis of the urothelial cancer trials, and there was a differential censoring. Could differential censoring explain the inconsistent results in phase 3 trials investigating the addition of PD-L1 inhibitors to platinum-based chemo? I'll pose this to Dr. Minish. Dr. Minish, are you around? So we were talking about the 3 negative trials which are prior to this trial which was positive. Could there be a differential censoring which led to the negative 3 trials and this became positive?
Possible, but I would still wait for several more answers. Means there have been trials with most of the drugs. It is how we sequence it or how we use it, or probably we have not understood it in full detail. So we have got an answer that immunotherapy works. We should retry. Now they have already seen that an ADC with an immunotherapy together is working. So probably, yes, I would say that the combinations, like whatever we have seen with atezolizumab, sometimes it has worked with certain combinations, and the same drug has not worked with others. So I would not consider, yes, but this is also one possibility and we should not ignore this.
Fine. So the findings of this reanalysis was that after the sensitivity analysis for censoring was undertaken, we found that the PFS and the OS benefit was lost in Checkmate 901. Vivek, you want to add anything?
Sir,
How
you
you
know,
view the
this
data?
issue,
Yeah.
correct, sir. So obviously, sir, this question that you say that why Atizo and Pembro failed, but only Nivo succeeded, does question us that was there actually a success or not? And when you look at the delta is not very huge. It is a minuscule difference of 3 months, and obviously in the PFS there is no difference at all. So this issue of informative censoring is something that's been discussed in multiple trials, and Dr. Ian Tannock and Dr. Vishal Gyawali, they have been discussing this issue not only in urothelial cancer but also in breast cancer, questioning the actual efficacy of monarchy and Natali in breast cancer also. So this informative censoring is something that questions the actual efficacy of the drug in the treatment arm. And I see that there is some problem with the trial design, or some twitching of the trial design, which has probably, or some twitching of the statistical design that has made this
Yeah, it was
trial
a
look
subset
successful.
analysis. It was a subset analysis, and basically whatever the results were taken out, it was basically a post hoc analysis, so as to say. Now, whether that should be, practice changing or not, that is subject to reason, and it can be argued both ways.
Correct, sir.
Right. Thank you. Next slide, please. So this is what we have discussed. What are the views on the available data of Checkmate, and how will you position? Any other thoughts, Dr. Shashank? Or Dr. Abhishek?
No, sir. No, sir. As the previous analyst has told, that whether
প্রড়বাধ্যা মানে কি মেন আছে না?
প্রড়বাধ্যা মেয়ে আর কি।
Hello. Yeah,
Hello.
Dr. Abhishek.
hello.
Hello. Yes, sir. So I think I agree with the Dr. Saurav, what he has made a point that probably this is not the correct combination. Maybe this is not the right way. Last year, Dr. Ian Tannock was here in Lucknow, and we raised this question that why these data, why these trials were negative trial, and we have a positive. So almost he also echoed the same thing. Probably he was saying that maybe the best approach in urothelial carcinoma is the maintenance strategies, switch maintenance. So maybe that is what I would take forward this data as.
Yeah, fine. Thank you so much.
Correct.
Next
So
slide, please.
just a small input, sir, that if you look at the Checkmate data, you clearly see that for the first 6 months there is no separation of the curves, and the curves only start to separate later on, and there is absolutely no difference in the PFS, which probably tells you that upfront immunotherapy along with chemotherapy probably works in only a small subgroup of patients. Now this subgroup is something that we have to identify. They looked at this very small subgroup of lymph node only disease, but if you talk to the investigators of the EV Pembro, so they say that even in the EV Pembro, if you look at the small lymph node positive only patients, there also there was a huge separation. So probably this lymph node only disease is a better prognostic disease as compared to the other disease. So what we could only understand that yes, avelumab as a maintenance probably is a very acceptable strategy, and we should not be thinking that patients would be missing out on the immunotherapy right from the beginning, because the trial has clearly shown that it doesn't work in the first 6 months with the chemotherapy, and it works only later on, probably in those patients who were already responding to chemotherapy.
Yeah, and if you dissect it out a bit more further, the lymph nodes, if you see on a scale of 100, it was surprising to see that only 10 to 15% were actually, distant metastatic lymph nodes,
Correct,
whereas
sir.
the other lymph nodes were, regional or otherwise, which explains that definitely in regional lymph nodes it would work very nicely as compared to, the cohort was not, I should say, evenly balanced. Right. Next slide, please. Next slide, please. So we switch over from the checkmate to EV302, which was a new kid on the block. And this was a combination of EV plus Pembro versus the Gemsys standard combination. But as you see here again, only 32%, that is 1/3 of the patients received avelumab maintenance in the control arm. And this was continued till progression or toxicity. And even in the GEMS, your patients did not receive EV in the second line. Next slide, please. And you have the, difference in the median OS that is about, again, double 15 and 33.8, which is a little bit more than the switch. And so is the PFS. Next slide, please. The safety outcomes, again, they are a point of contention whenever we talk of EV. And this is associated with a high incidence of adverse events, especially peripheral sensory neuropathy, dermatological pruritus, alopecia, maculopapular rashes, diarrheas. So these are there, and about 40% of the patients had dose reductions, and we had 4 deaths in this trial. Next slide, please. And here again, this is very, very interesting. A person who has peripheral neuropathy and has completed the treatment, out of those, 40% have residual grade 2 or more skin reactions, and 50% have grade 2 or more peripheral neuropathies. So this thing is not seen in the other combinations. So you have almost half of the patients who are elderly patients and who have completed their treatment and have had peripheral sensory neuropathy have more than grade 2, which is, tying your buttons and doing daily chores, writing, all this gets handicapped. Next slide, please. So let me ask Dr. Ravi, how important is the adverse event profile for selection of therapies in the palliative setting?
Yeah, it's very important, sir. As it was discussed earlier, what we see in OPD and what the clinical trials, they are a little bit different. And especially in our Indian subsets who are diabetic, elderly, multiple comorbidities, already with some baseline neuropathy. So it plays a very important role. Though data with EV Pembro looks very promising, whether we will be able to deliver to our patients is questionable.
Right. Dr. Minish, you want to add anything to it?
See, first is the cost of EV. EV itself is going to cost, even with you have to buy 100 milligram, it will cost you 2.32 lakhs. And then 50 milligram will be free, plus the toxicity, and plus then pembrolizumab cost. So I would prefer that, it's better to go with sequencing. Now, the advantage with that is you save cost, you are saving toxicity. You can always leave your EV to a next second line treatment. So that will be to the third line. So you give gem carbo, avelumab, and then EV, or gemcis, avelumab, then EV. That's a better way of giving the drug, I feel, at present, with the cost constraints at our place, plus the toxicity pattern. It's always better to go with a milder pattern and go with one treatment at a time, go to the next one, go to the third one, go to the fourth one. That will be the better choice, I feel, presently.
Yeah, you're right. See, apart from the fact that cost is definitely there, if you give two drugs, one is ADC and the other one is a immunotherapy drug, you add both of them, when you get side effects, for instance, if you get rashes or if you get diarrhea, it becomes slightly difficult to differentiate what is the reason for what. And on the other side, if you're giving switch, you are reasonably sure as to what is going to be the side effect and how you have to tackle it. So practically speaking, also it makes a lot of sense to give switch first and then uh, put the patient on EV or any other FGFR inhibitor in the subsequent lines. So, Dr. Saurabh, anything else you want to add?
So, sir, basically the toxicities, if you see, these are even if grade 1, grade 2, they are very much persistent toxicities throughout the so EV treatment. Patient would be having those toxicities, really makes it difficult to manage the patient. So in the frontline, EV lifelong continues. So patient takes more. So it is better that we go for subsequent second line EV. Patient is less is on EV for a limited duration.
Correct. Next slide, please. So this was the criteria, the EVITA criteria, which was proposed by Professor Enrique Grande as an editorial in the European Urology Journal, in which we see the performance status, the glycosylated hemoglobin, the GFR, the corneal or retinal abnormalities, and of course the level of sensory neuropathy. And at least two of these criteria may be deemed making EV unsuitable, EV pembro, for the treatment in the first line. So for instance, if you have a grade 2 sensory neuropathy, which you may find in the diabetic elderly patients or a poor performance status, these patients would not be brought into the eligibility criteria. Next slide, please. So if you look at the characteristics and the criteria, what percentage of patients may have the characteristics of EVITA criteria? Dr. Chandragoda or Dr. Vivek, anybody can take it. Dr. Vivek or Dr. Abhishek?
Yes, sir. As you have already mentioned and highlighted that in palliative setting, definitely the side effect profile is the important factor regimen we are going to start. Our patients are having multiple comorbidities to start the chemotherapy, and when especially the diabetes part is there, and they will be having some sort of peripheral neuropathy before starting the therapy itself. So in that scenario, we have to be cautious, and especially if I have to tell you about my take on this, that I don't jump on this regimen, though we have the data suggesting that it is a good combination. I'll still use first line as the chemotherapy followed by the switch maintenance, and I will reserve this drug in the second line till we have enough data from our Indian experience to suggest that how safe we are to use this drug.
Yeah, not only, it is the peripheral neuropathy at the inception, and as Saurav mentioned, the half of the patients have grade 2 or more residual peripheral neuropathy, which is, a humongous problem. So that adds on to the woes of the patient. You might get well, but at what cost?
Yes,
Your
sir.
handicap.
Yes, sir. Sure.
Vivek, are there any criteria you may want to add or remove from the criteria?
So I think, sir, when we talk about the EVITA criteria, they are there basically in order to make sure that we select the right kind of patients who do not have higher toxicities from Keytruda, from the enfortumab vedotin, but not from an efficacy or an acute safety kind of point of view. So if you look at these criteria, and I talked to a couple of investigators who were there involved with the primary trial, or some of the practitioners from US who are constantly using EV. So they are not applying this EVITA criteria very stringently in their clinic. HbA1c more than 8 is something is a chronic issue, and if you can control your diabetes well in a short duration of time, then you can take these patients probably safely. Um, Also, yes, retinal problems and neuropathy, these are definitely issues. So these I won't want to remove. But again, the HbA1c criteria is something. The ECOG PS is something which is dynamic. Again, you can question whether ECOG PS criteria is a good criteria or not. And the creatinine clearance below 45. So again, biologically there is no rationale, because enfortumab can be used in patients who have a creatinine clearance of less than 45 also. So there is a lot of criticism of this EVITA criteria, sir, and largely in the clinic, from a safety, long-term safety point of view, these criteria are there. But if we are vigilant for the toxicities, maybe we can so skip 2 or 3 of these criterias, and maybe a more liberal in using these. Otherwise we would be restricting the use of enfortumab vedotin for a lot of patients.
Yeah, this was an editorial, and it has to be accepted by, the oncology fraternity. But I
Correct.
guess you're right. The two criteria which are dynamic, one is the performance status, and second is the glycosylated hemoglobin. Probably they can be tweaked, but the other ones, like the kidney function status, the peripheral neuropathy, probably we should have that as a benchmark, because as of now, we don't have a robust biomarker on which we can base that, yes, for sure, this drug will work in those patients. There are trials with nectin and other antibodies, but then, there is no finality as far as a robust biomarker for EV is there.
Correct.
So when that is not there, probably 3 of these criteria would be in vogue whenever you embark on treating patients with this drug. Right.
So,
So
sir, in the
maybe
trial,
we add
when they looked at the biomarkers, and especially the nectin, so the nectin IHC expression was not very strongly correlated with the response, but the nectin gene amplification in the NGS or fish, this was actually associated with a better outcome. But still, nectin is not like a biomarker
That is
that
what
is to
I'm
be
saying.
tested before.
There are, thoughts about nectin-4, but
Correct.
the issue remains that it is not across the board. If you have a
Yes, sir. Yes.
biomarker, it should coincide with the oncodrivers. That is not the exact situation as of now. That
Correct.
thought process is going on. Saurav, you want to say something?
So, I would just like to share 2 of the patients in which we use EV. So I had this experience. Renal failure is actually a problem. If patient is already having a low creatinine clearance, it is better to avoid enfortumab vedotin, because there is severe dermatitis and toxicities which can happen. The second thing is that, sir, if there is a jaundice or if the bilirubin is high, and it is more than 1.5 times the normal, we should be careful about use of enfortumab. So probably inclusion of liver function would be something I would be careful about before using EV.
See, that was, one of the criticisms of this trial, where when you're giving EV, you're giving it, till progression. And when you're giving Pembro, you're giving for a defined period of time. Vis-a-vis the control which you're giving, that is chemo, you're giving it again for a defined period of time. Now, logically speaking, EV is a kind of a chemotherapy. You're giving it continuous over a very long period of time. So the comparison, is suspect.
Yes.
How can you give something for, heaven's end, and on the other side you just give for 6 months or probably less, and you compare and say that yes, this arm is better and that arm is not faring well. Anyhow, these are the clinical trials, so you have to go according to the inclusion criteria. Next slide, please. Next slide, please. So this I think we have talked, and we find that when you talk of the javelin regimen, 90% patients are eligible for first line, whereas you have about 50% for the checkmate and about 80% for the EV. Next slide, please. So, Dr. Abhishek, in your clinical practice, do these patient eligibility percentages reflect similarly? Or you find that it is the same? Or I think, Saurav, you can take this question.
So, sir, I would agree with that. So many of our patients are actually platinum ineligible to start with. Creatinine clearance is less than 30 for a lot of patients. So, so basically many of them would not qualify for this platinum, cisplatin at least. And as far as the carboplatin eligibility is concerned, so I would say that's a reasonable number of patients who are eligible for carboplatin, and completely platinum ineligible would be around still around 20 to 30%.
Fine.
So, I just echo with Dr. Saurabh. I mean, complete platinum ineligibility almost 25 to 30%, not more than that. At least a good number of patients can receive at least carboplatin. Even the cisplatin also, eligibility, if I have to define in term of percentage, almost 50% patient, they might receive cisplatin.
So that caveat is there and it is well taken. Good. So next slide, please. So now we have talked about the clinical trials and real world evidences. I think we'll just quickly finish it in the next 5 to 7 minutes, because any drug which does not do well in the real world, it doesn't make the data robust. Next slide, please. Next slide, please. So this, as it has been earlier told by Dr. Chandragowda, you find that the registration trial and the real world evidences across the globe, you find they're almost the same, whether it is the PFS or the OS. Next slide, please. And this is our study also. We also had a median PFS of about 5 months, and OS has not been reached till now. Next slide, please. And these are the outcomes with the EV and Pembro trial. You find that there is a discordance between the 12-month PFS and the 12-month OS as compared to the real world trials. Next slide, please. And you have the global real world evidences and the Indian RWE. Do we resonate in your clinical practice? Let's ask Dr. Ravi.
Yes, sir. Generally, this is what we see. Our patients will be having a lot of comorbidities. We do dose modify our drugs to a certain extent. The period of starting avelumab may vary with various because of mainly financial this one, but we still do see the responses. So I think it clearly matches our real world experience.
Right. Thank you. Next slide, please. How would you sequence these therapies for the 3 approaches we have discussed? Let's see what Dr. Abhishek says. Or Dr. Shashank?
So Dr. Shashank had to leave, so a couple of minutes back he has just messaged.
Okay, so I think we'll wrap it up quickly. Can we have the next slide, please? Can we go to the summarization in the end? The
one slide more, please.
Next slide more. Next slide, please. Yeah.
So, Abhishek this side, sir. Sorry, there was some technical.
Yeah, Abhishek, I would like you to summarize this. Now, you've given a choice between switch, EV Pembro, and the checkmate trial. I think checkmate would be a poor third as far as I'm concerned. So that leaves us with switch and EV Pembro.
Sir, already I have mentioned before only that still I have more inclination towards the chemo followed by switch maintenance, and I will keep EV Pembro reserved. So far, we have many more data from our Indian setting, and EV I will be using in second line. That is, I have reserved it as my plan of action. In fact, I wanted to ask you a question. If a patient who has been given chemotherapy followed by switch maintenance, and now the patient has progressed, what is your personal choice of therapy, sir? That is the question I wanted to ask you.
Definitely, there is a trial to suggest that if you give EV, then you still get a OS benefit of about 8 to 10 months over and above the switch maintenance.
Right.
And I would ask Satya when he's going to summarize that you have given switch and the patient is FGFR alteration positive. So would you like to give EV or would you like to give FGFR inhibitor? So I think I'll stop here. We had a very lively discussion, paucity of time which made us stop. And Dr. Harshveer is staring at me virtually. So absolutely. Thank you so much.
Sir, that was a knowledge stare rather than anything else, sir. Please. But sir, thank you so much for leading this insightful interactive discussions, covering these advances, getting the clinical scenarios, and then making them count from a clinical practice is quite important. And with that, may I please invite Dr. Dattatreya sir for his closing remarks. Sir, over to you, please.
Thank you so much. And for the past 1.5, we actually have crossed 90 minutes, and we were supposed to end at 8:15. But the very fact that the engaging discussions kept on continuing beyond 8:34 now clearly tells us the involvement of the faculty today in trying to understand that the sea change happened in the management of MUC with the introduction and the availability of avelumab maintenance, and that made a meaningful impact in the patient's quality of life and in the overall survival. Now came the second fact is, and the second take-home message which Paul learned was that the real-world evidence mirrors the data of the classical clinical trials phase 3 data based on which the approval of the drug came. So in reality, be it global data or Indian data, the real world evidence more or less mirrors what we all learned from the randomized trials which led to the approval of avelumab. Lastly, the question of sequencing, and therefore it's so important that at least in some malignancies, especially MUC, sequencing plays a key role. And it's not possibly wise to subject the patient to some drug combinations which might actually end up causing more harm than good. And as treating clinical oncologists and medical oncologists, the basic premise of each of us clinicians is to have maximal efficacy against the disease and minimal toxicity to the patient. And that can be achieved best by going in a sequential manner rather than trying to use drug combos, which sometimes may cause more harm than good. And so we now have a chemotherapy combo followed by avelumab maintenance, and then we have the antibody drug conjugate. And as sir was mentioning lastly, when it's about in the incorporation of the FGFR inhibitors also. So that sequencing after the initial treatment with the mutation present in the FGFR, I would possibly personally prefer using the FGFR targeting molecule first and then reserving the ADC EV for use after the FGFR inhibitor. There'll not be a right or wrong answer, but when we have a druggable target, so we start with the platinum-based chemo combination, get a good response or a stable disease. As long as it's not progressive disease, we go with maintenance avelumab, and then when progression happens, and you are able to find out a druggable target, we then go to a targeted therapy. And when that fails, whenever that fails, then we can think of using EV. And I think the discussions have been very insightful. And so I'm so happy and glad that it stretched beyond time, but kept all of us engaged. Thank you so much, one and all. Over to the medical team.
Sir, thank you so much for these crisp and important key takeaways for the audience. And that brings us to the audience. Towards the end of this meeting, we have had close to 140, 150 audience who have listened to this. And of course, in the coming times, a bit more. We will also make it happen and available virtually. But note to our audience, please also share feedback on the meeting. There is a feedback link which is provided so that we can also modulate our coming meetings accordingly. To our great faculty who joined us today, exceeding more than 20-25 minutes of a busy day, but really appreciate all the clinical insights, all the clinical discussions, especially for the audience, so that it becomes a meaningful scientific session. Dr. Dattatreya sir, for leading this scientific initiative, very much. Thank you so much, sir. Dr. Vineet Talwar sir, especially for his great moderation. Dr. Chandra Gowda and Dr. Vivek Agarwala for their great sessions, Dr. Abhishek Kumar Singh and Dr. Saurabh Kumar Mishra for the case sharings, which also become important for us to learn a bit more. And of course, joining them in the panel, Dr. Manish Jain sir, Dr. Ravi T sir, and Dr. Shashanka Das for their great discussions during the panel discussion. With that, thank you once again, faculty. Thank you so much, audience. We look forward to more such insightful and interactive discussions in the coming time. Thank you and wishing everyone a very good night. Good night, sir. Good night, everyone. Thank you so much.